So welcome. Thank you all so much for joining us this evening. My name is Dana Nobile. I am the brand manager here for Community Veterinary Partners, or CVP. We're excited to have you all this evening, and we're particularly excited to have you as we're celebrating Vet Tech Appreciation Week with you all. So we appreciate you all. You are the backbone of our hospitals, and it's so incredible to have this amazing turnout. Over 500 people register for this session. So we're so excited to have you. If you didn't know, CVP does host these monthly sessions every month. It's a different topic, but it's pretty much 98%, OACE available. So be sure to kind of follow us along and join us as we kind of explore different topics, different sessions. So today we are excited to welcome Alyssa Mages. She is a certified veterinary technician and the Chief Visionary Officer for Empowering Veterinary Teams, or EVT. Alyssa has over 19 years of experience in the veterinary field and oversees the content development and training programs for EVT. She's here today to share the fundamentals of veterinary anesthesia. So before we get started, just a little bit of housekeeping. So this course is approved for 1 CE credit hour. However, it is only available to those who attend the live session, stay till the end, and submit the form. We do encourage you to make the session interactive. So we have both the chat, as you can tell, and the Q&A open. So we'd love for you to kind of share your feedback, throw out your questions throughout the sessions. So with that, I'm going to go ahead and turn it over to Alyssa. And thank you again so much for being with us. And we're excited for your session.
Thank you so much, Dana. I'm really honored to be here with all of you tonight, especially since it's, the middle of the week and you're heading into who knows what, or coming from out of who knows what. And I just want to say thank you so much for spending your precious time with us tonight. So Dana did a great introduction. I'm not going to waste your time talking about myself. I just would like to share with you that my pronouns are she, her, hers. And these are some of the other organizations within VetMed that we work with and partner with. So a lot of DEIB and advocacy work with Possibilities and Blend. I have just joined the Vet Tech Champions team at BI, and I'm the director of Mentor Vet Tech. And we will be starting another organization focused on communication in the next year. So the other thing you might notice as we go through all of this and take a look at this lovely long list we're going to be talking about this evening, it's not in a normal font. And that's on purpose. So this is a font called Open Dyslexic. I was diagnosed with dyslexia several years ago, which made my whole childhood make a lot more sense. And so the spacing and the shaping of all the letters are supposed to make things flow a little bit better. So hopefully it'll help some of you as much as it's helped me. So this is a long list. Like Dana said, we do have a lot to get through. So the interactive piece is I'm going to have Caitlin, who is our COO and one of my best friend humans on the planet, help moderate that chat for us. Definitely don't want you to hold back on your questions, but if you could put them in the Q&A or the chat, and we'll get to them probably closer to the end. Or I'm just going to go really fast because it's automatically advancing for me. That's fantastic. Thank you, PowerPoint. That'd be great. So see, normal. Everybody, things happen like this. So we're going to talk about what is normal for each patient. Definitely talking about how good drugs can be, looking into our equipment checks and making sure that we ourselves are checking out. And then we're going to talk a little bit about emergency anesthesia versus routine procedures. Spoiler alert, there's no such thing as a routine procedure. And then we're going to get it down to the fundamentals. The title of Knock 'em Down and Wake 'em Up is simplified, and it's meant to catch your attention a little bit. Clearly, there's more involved in this than that. And this is really just to be a refresher for those of you that have been out of the OR or haven't been in there in a while. And it's the fundamentals, a framework to build upon. So if you want more detailed advanced, that's not this. It's a way to wet your whistle and get you started. So normal is whatever they are. It's determined by your patient's species, breed, and size. And that's shortened into an acronym. My team loves when I just make up new ones. Sorry, it happens. That's what SBS is in there in that sub bullet, that second one. Because it's dependent upon the environment that they're in. Is it a stressful situation? What their current mentation is? and again, species, breed, and size. So don't get over fixated on the changes that you're seeing, especially when you've knocked them down with dexdomitor and the heart rate of your Labrador is now 48. That's lower than we'd all get comfortable with, but just keep in mind that's the drug doing its job. And when you get into the anesthetic portion and you get stimulation from the surgeon, hopefully that will alleviate itself. So you're going to expect similar readings to resting heart rate values. I mean, think about how big a Great Dane is versus a Chihuahua versus a Sphinx. They're all going to be different, but think about what their normals are at rest and expect that you'll find that on your anesthetic monitoring equipment, but also the unexpected, because anesthesia, it's a steady state of emergency. So this is a really helpful chart that we've extrapolated from the sources that you see listed there, vasg.org and Colorado State. It's, again, you're going to have extremes on either end of the spectrum, but this is the averages that tend to work out across the board for both cats and dogs. Another disclaimer, this is focused on small animal. It's not exotics or large animal. So I apologize for those of you that are friends with the hooved and scaly and feathered creatures and the little ones that fit in your pockets. Chihuahuas do too, to be honest. So maybe they could be a pocket pet, but we are going to be focusing on cats and dogs. So those of you that are looking at this going, oh my God, what does this all mean? It's okay. Break it down. So if you're thinking a TPR, right, you're looking at your temperature, pressure, and respiratory rate, and then you're getting into your blood pressure there on the end. And I'm hoping these animations don't keep doing that for me. But your mean arterial pressure is your average, is what we're really caring about for the most part. And that's going to be on your oscillometric, the one that you put the cuff on and push the button and say, give me numbers. It's going to work on your larger patients. Really want all of you to think about getting comfortable with a Doppler, especially for your patients that are, 10 pounds and less. And that's typically associated with the systolic pressure. There is some literature that it's more closer to the mean. We'll figure that out eventually, but generally know these numbers is what you're looking for, right? And if you don't trust your equipment, it's older, it needs some maintenance, this is the calculation for you. Stop it, PowerPoint. We're going to fight with this all night, and that's going to be super fun. I won't be annoyed at all. Anyway, so your MAP is the equivalent to your diastolic pressure plus 1/3 or 0.033333 multiplied by the systolic minus the diastolic. And that's an example there for you. So I'm really glad that we're going to be able to give this to you in a recording so you can take a look at it. And we'll be happy to share a PDF copy of this with CVP to send out to all of you as well. So keep these normals in mind as you're heading into your cases and know that things will shift, but this is what we're looking for. I tend to not get happy when my pulse ox is less than 99. I like to be an A+, but you can get to 95 before you have to have a little bit of a moment, okay? So drugs are good, the right ones, right? And this is what we're going to break down this section into. At what time throughout the procedure are you going to be giving these things, what routes of administration you're going to be utilizing, and the types and classes. Those are not the same thing, right? So really thinking about your analgesics, antibiotics, and induction agents, all of those kinds of things, as well as the interventional medications. The type of medication is that category, right? And then your classes are the specific ones within those categories. So if we're talking analgesics, you have those types within it are going to be like your NSAIDs and your opioids. And then within those are the specific classes, like your full muse and partial agonists and whatnot. The other things you have to consider before you select your anesthetic protocol is who's making it. Is it dictated by your practice? You've got to have a doctor supervising that. Do you have an anesthesiologist on board? I'm very jealous if you do. And what is your role within that as a credentialed veterinary technician or as a veterinary assistant? What are you administering and how do you do it? And what are those side effects, right? Especially if those are things that are contraindicated, right? If they are coming off a washout period of steroids, maybe you want to wait on that injectable Rimadyl. So taking all of this into consideration is then going to determine which drugs go where, right? So this is a little bit more of a breakdown of those classes and types that I was talking about just a moment ago. So the analgesics come up first. They're my favorites, right? They do the biggest bang for your buck. And you know a lot of this. And if you don't, that's what Plums is for, because please don't think you have to know every medication that you're utilizing, all of the doses, all the dosages, all of the contraindications, all the indications. Oh my God. No, you're not expected to know and remember everything. The top 5 to 10 drugs that you use the most, get really familiar with those. Absolutely. But opioids, we're talking butorphanol, buprenorphine, fentanyl, morphine, which we don't use too much anymore, torb either, and hydromorphone. And you got your alpha 2s, which is your dexamotor, and then your NSAIDs, meloxicam, Rimadyl, things like that, and steroids. They are considered an analgesic. If you use them in an oncology protocol, then they're chemotherapy. That's a whole other session. Your interventional medications, thinking about when you have to step in if something's not going well, right? So these are your pressors, these are your antiarrhythmics, and the most popular one for antiarrhythmias is a numbing agent as well, and for visceral pain, good old lidocaine. Gotta love that drug. And then you've got your norepi, your vasopressin, your dobutamine, dopamine. Those are your pressors. Atropine is an anticholinergic, so that's not listed, but that's definitely one to be aware of, as well as glycopyrrolate. So if we're looking at increasing the heart rate, those are the two you want to know about. GI, do you use that as part of your pre-induction protocol? If you don't want them puking, right? And anti-nausea to make that keep going. And then GI motility, if we're worried about foreign bodies post-operatively. Anesthetics, that they're focused on knocking them down. That's your benzodiazepines. That's your midazolam, your diazepam. You got your hypnotics, which is propofol and alfaxan. Taxolone is in there as well, and your general anesthetics for your inhalants. All those fun things. There's a lot, right? So make sure that you talk to your doctors and your team and develop that protocol together, which is what that last section there at the bottom of this, what you're seeing on your screen is. It's going to be specific to your practice, but it should be focused and tailored towards each patient. It shouldn't be a blanket protocol. And you want to use a lot of different medications because some of them are going to last longer. Some of them are going to help you with pre-medication and relaxation. And you really want to make sure that your patients have ongoing analgesic pain management throughout the procedure and into the wake up recovery period. It's going to make their life better and your life easier. So parenteral is avoiding the oral route, right? So this is IV, IM, and sub-Q. And think about which medications can go where, right? So if you're doing hydromorphone as part of your pre-op, you're making them feel better protocol. Remember, if you do it intramuscularly, what's going to likely happen, especially for your canine patients, right? So be prepared for that. It's also going to increase their respiratory rate. If you're doing IV, it's not going to last as long. And always, 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 when you're giving an injectable medication, especially intravenously, make sure that you check the catheter's patency first, and also do not administer faster than between 30 to 60 seconds. You don't want to slam that in there, especially propofol. We've all seen it happen. And even if you all haven't, it's not good. Purple is generally a not good mucous membrane color. So nice, slow and steady does it. Oral medications, sometimes you're going to do a Gabatraz protocol before they even get in the hospital. One of my favorite cocktails. It's delightful. Sometimes we wish we could give it to the clients, but I digress. And then your inhalants. So your sevoflurane or your isoflurane. The timing here is really going to be dependent upon your caseload, the types of patients you're working with, and what do they need, right? So can you get a catheter in without pre-medication? You can. Do you need to? Maybe not. It might be nice if they had a little something on board to take the edge off. You can also do some topical lidocaine gel and see if that helps with some pain there. It's a big needle if you're putting an 18 gauge, and there is some pain associated with it. But if it's a sharp one, if it's a Terumo, I swear we're not sponsored by them, but I love those catheters. It tends to go very smoothly. And think about your duration, like your mechanisms of action for these medications too. If you've given your pre-med dose of, say, methadone, how long is that going to last? No, I'm not telling you the answer. You have to figure that out. And when are you going to calculate it to determine when they need it post-operatively? Be kind to the people coming in the shift after you, as well as the owners that are picking them up. Make sure that they have a little bit extra on board to get home and feel comfortable. Tapering is primarily geared to, I'm thinking here, if you're doing the following two, total intravenous anesthesia or a CRI method of injection and constantly keeping that going, but it's also applied to your inhalants. Not with Sevo. I honestly, for the majority of my career, I worked with isoflurane, and you needed to taper that because it took a while for them to off gas. Sevo, they're up and out of them in like 37.2 seconds. And that was a quick learning curve about 5 years ago for me. So what I'm talking about here is being aware of not only the anesthetics that you're providing and the maintenance and the care of the patient, but what's happening underneath the drapes. And that you can see when they're closing the subcutaneous layer and then the skin and what the reactivity level is going to be. And you can modify your doses from there. Equipment check. And I know we haven't even got to the knock them down phase. So, and I apologize, I am from Philly. I talk very quickly. So questions, please let me know what they are. But again, we'll make sure that you have these notes. This is before we even knock them down. You have to make sure that everything that you're going to be utilizing for the procedure is ready to go. So this is the anesthetic machine that's in the prep area and in the operating room. It might be the same one, it's portable. Whatever it is, make sure that your scrub system is ready to go within it, like your soda lime, and that your scavenge is attached appropriately. If you have a carbon filter in there, that's changed, that your inhalant levels are up to date. You don't want to fill that the morning of. It's probably best if you do that the night before. And make sure you have the appropriate circuits and the reservoirs for your patients. General rule of thumb for your reservoirs, your breathing bags, it's 1 liter per 10 kgs. And if it's anything less than 5 kgs, it should be on a non-rebreathing circuit. You can work with a pediatric circle system. I prefer an F circuit. It's whatever you have in practice that you're comfortable with and have utilized, and make sure you check them for leaks. You want to ideally replace these at least once a year, if not twice. So you want to clean them out with soap and water. Don't use any chemical cleansers. Just Dawn dish soap is great. And make sure you rinse that really thoroughly and spin it around. It's kind of a fun game. See how much, you can get your teammates wet with that. And then the other supplies you need to check and make sure you have ready: a laryngoscope. Old school training, yes, I can intubate with that one. Should I? No. Because you're not just putting a tube down the trachea, you're taking a look in there at the tonsils and the laryngeal folds and any of the everted saccules in our brachycephalic fronts. You're the first place where you can see that and make sure everything's okay. Lubrication for the eyes and the tubes. Just avoid getting lube on the eyelet of your endotracheal tube. How many tubes are we getting together? 3. Always 3. One size that you're pretty confident that it is, and a half a size or a whole size up and down. And how are we measuring them? The diameter of the nostril, it does work. It's not always accurate. I like to do an external measuring of the trachea itself. And then the length of it too. Watch out for that dead space, right? The tip of it should go no further than the thoracic inlet, which is also even with the point of the shoulder. Okay, and if there's extra dead space there, which is called mechanical dead space, not anatomic, you can cut it, but I'm not telling you to do that. You need to talk to your head tech or your doctors to make sure that that's okay before you go ahead and do that. Gauze squares and whatever you're using for a tie. So you can maybe have that the stretch gauze that you tie around the muzzle behind the head. Sometimes you use old IV tubing, and then in dentistry land, there's that lovely orange stuff that snaps, and it also doesn't get tangled in the fur. Something to think about with those curly poodles that are going to lose their teeth by the time they're 7.2 years old. And then your monitoring equipment. Make sure that you have something that counts the beep beeps and the thump thumps, but it's not something that you just stare at, right? You want to make sure that you are actually physically using your stethoscope and your very good diagnostic tools, your fingers, your hands, and your eyes. But something that has everything in it, a one-stop shop, is going to make your life a lot easier. So that has the ECG, it has a pulse ox, has a capnograph for your end-tidal CO2, and it has a thermometer probe, which is super nice. Dopplers for your smaller guys. And is there anything else that I'm missing for monitoring? Yeah, I didn't have a stethoscope up there. Should have a picture of that. And especially it's Vet Tech Week, you should enter in all of the sweepstakes to get a free one. Littman is going crazy right now, so make sure you have that in there. So this is all the things you need to check before you even touch your patient with any anesthetic. How about yourself?
Alyssa,
Yes.
we had a question on the chat that might be good to address on that previous chart. It was about preparing your tubes, washing your anesthetic tubing and bags. And this person and Erin was taught to never wash them, to use a humid vent and then replace as soon as it gets gross. So I don't know.
Maybe I can pull that up. I'm not really clear on the question. So you were taught not to actually put water in the circuits and the bags at all. Am I understanding that correctly?
That's the way I read it as well. Yep.
Okay.
She just agreed.
Thank you so much. I appreciate you for clarifying that. Again, this was how I was trained. It's something and because I've done that for so long that way, as long as they're dried appropriately, it shouldn't cause an issue. You actually should fill your bags up with more than just air to make sure that they're not dry rotting and cracked and they're not leaking. So I'll definitely do some research and send an email out to Dana and the team to make sure that I have that information correct for you. As far as I've been told for the past too long, it is okay. It's when you wash it with other things such as like simple grain or any of the other chemisols and things out there that it can get really scary because the residue doesn't fully clean off and you don't want them inhaling that. But it's a great question. So thank you for keeping me on my toes. It's necessary. Things change. So I will look into that and we'll definitely get you an updated response. Thanks, Erin. And thank you, Caitlin. All right, you got to get yourself in a good space for this too. Anesthesia, I had one professor that told me, you should be terrified every time you walk into the OR. Thanks for that. I already was, and now I think I need a UCAF myself. It's something to have good nerves about, because if you aren't nervous, it means you don't care. But I don't want any of you to feel like you can't do this. You absolutely can. So just make sure that you're checking in with yourself and you're not distracted, and all of these things listed here. I'm not going to read everything bullet pointed out for you about your patient, and that the records are up to date, and keep things going as you go. Check in with yourself, check in with your team. If it's your first thoracotomy, please don't be in there by yourself, please. And your team shouldn't put you in that situation either. So really make sure that you're communicating with the doctors, with the other technicians, with your assistants, and with your receptionists, so that everyone's on the same page with everything that you see here on this screen, because that's what's going to make an anesthetic case go smooth. So I mentioned it briefly earlier, but I have always referred to, and again, this is another mentor of mine, that anesthesia is a steady state of emergency. So you kind of always need to be ready, because you're not sure what's going to happen. And if you're prepared, you should be fine. So what I mean by that is you don't really ever want to get complacent and sit there and like, oh, the ECG's beeping and I see I think, yeah, that looks like a PQRS and a T. Yeah, it's fine. But you're not touching your patient. You're focused on writing the records, or you're updating your charts. And now I get it. When you have 17 cases and you're the sole surgery tech and you have to get it going, and you've done this 1,300 times before, you kind of get that way. I would encourage you not to. So make sure that instead of getting complacent or panicking, those two extremes, get into like this place where you're focused on a different kind of TPR. And that's what that timing, priority, and response is, right? Know when things are needing to be done, prioritize them. And instead of freaking out, which is what a reaction is, right? Think back to chemistry. It's fast and it's intense and it's hot. A response is a reaction, but with thought and time. So when you're talking about the true emergency cases, like you have a ruptured spleen or the condition that I will not say out loud because it will come into one of your clinics and I don't want to be responsible for it, but we all know what we're talking about. Make sure that you have kits ready to go. You have a blocked cat kit. You have that kind of kit so you can prep it and get it into the OR. You have everything staged and you have people assigned to their roles so that you know exactly who's doing what, where, when, why, and how, and it can run like a standard TPLO or an OHE from the morning. So what does it look like? It's a cycle, right? So we as the techs are going to make sure that we get all the information, all of the things ready, talk to the client. Doctor comes in and is like, hey, what are we doing today? And you're like, look at your surgery board and here's your patient. Please put your hands on it and take a listen. And then you focus on your patient, right? You get them pre-medded, you get them ready to go, have all your supplies ready, and then the surgical process can start. Same as for a standard procedure, it's just going to be a little bit quicker. But being fast is not the same as rushing, right? You don't want to be tripping over your Crocs if you don't have them in sport mode. And now you're ready to knock them down. Every practice should have their own induction protocol. And I don't just mean what drugs you're using. What does the timing look like? What steps are you doing? When are you priming the lines? When are you flushing your lines? All of these things. So when you're inducing your patient, what I'm talking about here is making sure that you're checking the patency of your IV catheter, administering the anesthetic drugs, making sure that you get the laryngoscope, have your assistant open the mouth and you can take a look and you're like, oh yeah, I picked a 7.5 tube. That's perfect. Oh, just kidding. It's an English bulldog. It's a hypoplastic trachea. Good thing I have a 6 here. Oh, it's really tiny. And you know where your sterile tubes are, you can get it going. So when you're looking at intubating, make sure that you're in the right tube, right? And we all know how to check that, I hope. Get the tube in, see if you get condensation in air, listen. And if you're attaching, you're turning on the oxygen first, right? You want to make sure you don't want to attach the anesthetic circuit and there's no air flowing. Breathing is a good thing. And our brachy dogs really appreciate that even more. So that's when you're going to do your leak testing. You've leak tested your cuffs on your endotracheal tubes before. Make sure that they're not leaking. Deflate those, get the tube in, and do not inflate the cuff any more amounts of mils of air past if you hear leaks. So you shouldn't be the one that's administering the breath and checking for leaks. That should be a tag team process, right? Get your monitoring equipment attached up, then turn the inhalant on, get all the records lined up while your other teammate is prepping the patient and shaving, clipping, cleaning and things. And now you're ready to roll. Sounds easy, right? It's only 17.5 steps. Take your time. Even if you have those 17 cases, I'm picking 17 a lot. I should play the lottery. Anyway, if you have a lot of cases, rushing through them is not necessarily going to make it go faster. And that's when mistakes can happen. Make sure that you've crossed all your T's and dotted all your I's, and you're using your anesthetic record to keep you on target. Because now you're heading to the OR and you have to hook up all of the things. So again, make sure that you're working with your practice team members to make sure that there is a order of operations. Okay, when you get in there, you're going to get the patient on the table. Someone's getting the legs secured. If it's a TPLO, they're hanging it appropriately, whichever side they have to be on, whatever position, if they're dorsal or ventral. They might even have to be at an incline if we're doing a PU. And then what order are you hooking up all the things? Well, think through it logically. Patient needs to breathe. Okay, anesthesia machine, priority number 1. Some practices, they hook up the IV fluids right away. So you don't forget at the end, and we can keep that hydration status, because chances are if they've been fasted and they're older, they're dehydrated and their pressure's not great to start with. So get that back on board. And then I like to start with the pulse ox after that, because it gives me two things. For one, I can hear my actual heart rate and I know what the SpO2 is actually reading for me. And then you're going to get in your zone. Whatever route you choose, whichever order you put things on your patient, do it the same way every patient, every time. Same thing for doing a physical exam, so you don't miss anything. You don't forget. And again, there's no right or wrong answer here. Do what works for you and what's based upon the protocols in your practice. And breathe, because if we have to do CPR on the pet and you, it's going to be a really long day. So make sure that your knees are bent, you're hydrated, you've actually gone to the bathroom. Yes, you can afford to take a 30-second bathroom break, please. And then make sure you are focusing on these things listed below. You know these. These things are what keeps the patient alive. We need to make sure that the thump thumps and the whoosh whooshes are working. If you aren't lucky enough to have an esophageal stethoscope, it's one of my favorite tools to have in the OR. And especially if you don't have to move around the drapes and worry about if it's blue, it ain't for you. It gets a little trickier if you have an esophageal attachment for your ECG, but it shouldn't be a problem. The only time you can't use an esophageal stethoscope is 1, if you don't have it, but 2, if you're doing a GI procedure, especially the condition I won't say out loud, because other things have to go down there to empty the contents. But you're listening and feeling for your majority of these parameters. The esophageal stethoscope makes that a lot easier, having an ongoing temperature probe. And my favorite thing to focus on all of these is your end-tidal CO2. So getting a capnograph is actually, it's going to measure the alveolar gas exchange. So it's going to be really indicative of perfusion. And then write everything down while you're keeping them alive. Every 5 minutes, you're going to be checking heart rate, respiratory rate, pulse quality, blood pressure, and pulse ox. Every 10 to 15 minutes, check your capnograph and your IV fluid rate, what the inhalant percentage is, what the flow of oxygen is, how many liters per minute, and the patient's temperature. That's what I've been taught. That's what I recommend. Again, everything that we're talking about this evening is recommendations and what I have as a lived experience and members of our team that are currently practicing in anesthetic positions. It can change. Nothing's written in stone. Take notes anytime anything has been done, like when you've administered cefazolin another dose, when you've noticed this is happening, when the temperature's changed, and communicate it with your doctor. They're elbows deep, they're not paying attention. And if they're drilling and the music is blaring, they are really not paying attention because they trust you. And they should. You know what you're doing. First and foremost, when you get to this page though, do not panic. So of course, when someone tells you not to panic, what are you going to do? You're going to panic. But that's when you go back to what I said about chemical reactions. Respond. Take a quick, okay, what's happening? I have all this ready. I've pre-calculated my interventional meds if I need them. What is causing this? All right. Well, oh, shoot. That's the induction percentage of ISO. I should turn that down from 4.5 to 2. Take the lines off, flush them out with oxygen, reattach them. Warn people, because if you don't have an active scavenge system, you guys might get feeling a little bit high yourselves. And understanding what's happening and going step by step focus on the facts, and the emotions tend to take a back seat. So your panic will hopefully get under control there. If your patient's too light, they're going to be reactive. If they're too deep, you can check the eye position and they're not responding to things, and the heart rate is going to be affected. If the SpO2 isn't reading appropriately, move the probe first. Wet the area, pick a different mucous membrane. There's lots of them. I know the pigmented ones can be really challenging, but there's pink somewhere. You can find it. And remember that your capnograph is going to be more helpful to tell you about active perfusion than your pulse ox anyway. If you have a decrease or an increase, are they breathing too quickly? Are they breathing too slowly? And then again, that's linked to other causes of the anesthetic depth or things of that regard. It could also be indicative of your endotracheal tube placement. So take your time and go back through what's going on. Take a look at your trends. A one-off low blood pressure, I'm not freaking out. 2 of them, I'm getting more concerned. 3, I'm definitely going to be doing something. It's not that I'm ignoring it, but I'm checking all of my other parameters and I'm checking the pulse quality. And then I'm going to go into, all right, going to decrease the inhalant. Okay. IV fluid bolus. Okay. We need to add a pressor. And the whole time I'm updating my team about what's going on. So ID what's causing it, get to the root of the problem, breathe, and get it done. Because now you fixed everything and you're an amazing anesthetic rock star and you get to wake them up. This is a gradual process. Again, maybe not if you have SIVO, so be aware of that. But if you're in a practice that has isoflurane, you're going to be paying attention to, all right, what has been going on this whole time in this procedure? What is it? What do you notice, right, when this is happening? So if they have drilled the placement pin and now they're cutting through with the sag saw, what all are you going to be noticing with your patient? If they're just like cool, calm as a cucumber, then you're at a steady plane. Well done. If they're reacting, then you know you have some work to do, right? Versus now when they're starting to wake up, this is where, okay, we are moving from the OR to post-op rads to bandaging to the recovery run or kennel. And what does that look like? So you've got to figure out what you need to do. If it's a spay, that's pretty cut and dry. I need to get them off the table, clean them up, get them into a warm place, and sit with them until I can take the tube out, right? So when do you deflate the cuff? I tend to do this pretty quickly, simply because I don't want them to get all the stimulation from transferal and go, oh, and I got to get the tube out and I got to figure out where my decuffer puffer is. The only time I tend to leave that a little bit inflated a little bit longer is when I'm worried about regurgitation or things like that. So I deflate first, I move them into their recovery bed, and then I untie. And I don't stimulate them. So how to stimulate? I don't. Unless I've been sitting there for half an hour and I have a lot more to do and I'm not just the recovery tech that day. So this is gentle, gradual pulling on the tongue a little bit, and you can gently blow in their ear. Please do not be like, wake up, I've got stuff to do, right? And especially with I keep picking on the brachy breeds. I love them dearly, but we all know that if they get a tube in, they don't want to let go. This is the best breathing they've had their entire lives, right? So for removing that tube on those smushy, beautiful babies, I don't until they're chewing on it. Other patients, I tend to wait until there's 2 or 3 swallows and they're kind of moving and looking around, make sure that tube is, that cuff is deflated, and you gently remove it all in one steady, smooth motion. Post-op meds, instructions, etc. Formulate them ahead of time, hopefully, yeah. And you get into a zone of things, especially if this is your spay and neuter day, this is your dental day, this is our ortho day, this is our soft tissue day, or if you work in a specialty department, you know 99.9% of the time who's going home with what. So you can have the labels printed ahead of time. You can work with your assistants and have this into a more, kind of like an assembly line type thing. The technician is focused on the monitoring and the recovery while the assistant is getting the meds ready and everything else. You have a discharge instructions template. Doctor needs to sign it, take a look, give the owner a call, let them know how things are going, and stay with your patient. Whoever is assigned to that case, it's yours until you've rounded the next person. Make sure you write up your records. Of course, you do that all the time. And that you're checking their temperature. How often? If they're cold, more often, every 15 minutes, but no longer than every 30 minutes until they're at normal temperature. Really great way to keep them nice and warm, even throughout the procedure beyond a a bear hugger or a hot dog or a hot water blanket is get little cheap baby socks, little baby booties, and put it on their paws, because a cold patient utilizes 300% more oxygen. They need more. So if they're cold, little flow by O's is not a bad thing either. You can also warm your IV fluids if you have like cages that are pre-warmed, like ambient flooring or radiant heat. I would like that in my own home. So I don't like being cold. Our pets don't like to be cold, especially our kitties. We don't want to cook them either. So you don't need all 5 varieties of patient warming, but make sure that you are having that as a part of your recovery protocol and you're checking their temperature. And similar to when we're cooling an emergent patient, you don't want to heat a recovery patient very quickly either. So a gradual warming process, which is again why checking in on them is so important. So I've been talking for a really long time, and I think there's like 7 questions in the chat there. So I'm going to kind of do a bit of a summary here, and then I'm going to turn it over to a Q&A a little bit, because we've talked about a lot, and I'd like to give all of you an opportunity to have some of your time and hear your voices. What I want you to keep in mind is, again, going back to that first slide, is normal is whatever they are. So there's those normal ranges, but know what's normal for your patient. So if they are typically pulse oxing at 96, don't freak out when they're 95, 94. Just don't let them get any lower than that, right? But also know what their heart rate is, understand what the breed predilections are, and be ready before anything happens. And that includes you, right? If you've had a really rough morning, maybe you can tap out with another teammate, because that is more than half of what you're facing before you get into the OR. Stick to your scripts, not what you're reading, what your doctors are prescribing, and what you're administering, right? Know what you're giving, give it steady and slow. I check my calculations. I have someone else check me. And then sometimes I just like to be really, really confident because I've had one instance where I overdosed a patient, and I will never do that again. And that's what happens with mistakes. Don't be afraid of them. Hopefully you find yourselves in a space of psychological safety where it's a growth opportunity and everyone treats it as a way to learn and become better and not as a belittlement. We're going to make mistakes, but that's why we have protocols in place to prevent those. Go backwards, you silly thing. Wasn't done. Apologize. Hopefully some of you are laughing now. This is on the record. Your anesthetic record is a medical document, so it's legal. So you need to make sure that it's in blue or black ink and it's complete. If we don't write it down, it didn't happen. Steady state of emergency, keep going, knock them down, keep them alive, and get them up and at them. And that's really the fundamentals. So beyond that, yes, there's more details, but keep it simple and you won't have to freak out. So this is a way to stay connected to us: website, email, and our social handles. And I know there's a little bit of post-op housekeeping, but before we do that, I'd like to dive into your questions. So Caitlin, if you would be so kind as to open that up for me so I can hopefully alleviate any questions that are flying around there.
Yeah, absolutely. And there's been some great chat as well. So thanks everyone for adding to the presentation. We appreciate that. Okay, I have one from Blossom. Hopefully I pronounced that right. And I might need a clarification here. It says, is there a risk on vaccinated a pet while they are under?
Is there a risk to vaccinate a pet while they are under anesthesia?
Wow, nicely done. I appreciate your interpretation.
It's from working with veterinarians that don't know how to, yeah, it's totally fine. It's a great question, Blossom. And it depends on the history of the patient, right? So I'm assuming, and I shouldn't assume, is this when you're talking about doing like puppy and kitten spay and neuters to kind of finish up their protocol? I wouldn't advise it. But again, it's going to be based upon what your practice's protocols are, simply because you're not sure if they've, depending on where they're at with their vaccine status too. If it's what stage in the protocol, if they've had multiple vaccines before with no reaction, you should be fine. But it could be that one-off chance where they have a reaction and you don't want to have them under anesthesia and deal with that at the same time. So it's going to kind of be up to you and your medical team of what you're comfortable with. It's not something that I did typically in the general practices I worked in, and definitely not in the specialty centers. It's not wrong. It's just something that I would keep separate, just so you can monitor the different things of what's happening. If it's a vaccine relation, or if you can, then you can focus on the anesthetic procedure.
Okay. She said thank you. Or
Yeah.
Blossom said thank you. I shouldn't assume pronouns. Another one from Blossom. When you knock them, I'm just going to read as is, so hopefully you can interpret again for me. When we hook them up to a dead machine, or do we put on both before we attach the ET tube to the non-breather or the rebreather?
I'm going to try on that one. You should definitely have base it on your patient's size, and you're going to choose the anesthetic circuit before that and have it attached to the machine prior, and then leak test it from there. So if your patient is over 15 kilograms and you're gonna, a circle circuit, like a Y circuit is fine. So is an F circuit. They have pediatric circuits for those as well. They're smaller diameter, so there's less mechanical dead space. But the rebreather, it does take a special attachment for those anesthetic machines, and they're different based upon the manufacturer. But you wanna have those attached before you induce and make sure that all the connections are leak tested and tight. Did I get that one for you?
I'm gonna wait a moment. Oh, yes, nicely done. Okay, this is from Danny. It's a two-parter, and Blossom says thank you very much. Okay, is there a way to confirm the ETCO? My doctor has told me not to write it down because of God forbid something happens and we can't prove on paper what the ETCO is during surgery. I'm going to make it ectoplasm before this.
Ectoplasma. I love it. Is there the untitled CO2? Tell me not to write it down. And I actually I can click on the button and take a look at the questions. That's helpful.
Perfect. I think it helps for the others too, though. So there's no way to, the question says there's no way to double check if there's a mistake, like you can with HR or temp, where you can double check.
Okay. So it depends on, and again, I'm not trying to be, I'm not coming up with the right adjective. I'm not trying to avoid the question. It's really going to depend on what type of capnograph you have. If it's a side stream or an in stream, and it's going to just really depend upon how that's actually measuring your end tidal CO2. You can check it. You can confirm it with one that's in the multi-parameter unit is going to be different than, say, like a standalone, like a handheld. So I'm not sure why they're not asking you to write it down, because you can't double check it. I would talk with them about it and see what their reasoning is. That there are ways that you can. I find especially coming from emergency lands for the better part of my career, it's way more accurate and indicative of accurate and effective utilization of the machinery, especially if you have to do compressions, God forbid. But if you're doing anesthesia, it's really showing the gas exchange and how, if there's an obstruction in the machine or in your patient in the airways or the tubing, it's going to be a way better indicator of what's going on there. So I would really take a look at what type of equipment you have and see if there's an option to have handheld versus in the multi-parameter unit, and if it's side stream or in stream.
Okay, and thanks to Kurt for throwing out another idea as well with calibrating with a canister.
Yes, thank you.
Okay, so this one is more of a statement, but I'll throw it to you in case you have any ideas of how to help this person make changes at their clinic. And it's from an anonymous attendee. They state that my clinic never pre-meds. I constantly have to keep my patients on a higher ISO flow. It's so stressful, but I don't have the authority to change it.
That's a tough situation to be in, and I feel for you. I have been there before. It's definitely something that I would recommend, honestly, just getting the literature to back that up, going to like the veterinary anesthesia nerds or on some other like AHA's guidelines and say, this is some protocols and this is some options and this is why. You can save money on oxygen tanks, which oxygen's not too expensive, but the transportation of it is. And do a cost benefit analysis about what it costs for the bottles of your inhalant versus what it would look like to do a small bottle of dextrometer, or looking at different types of analgesics, things like that. So again, I bring it, similarly to when you're dealing with like an angry client, or if you're dealing with, you're in a situation where it's kind of stressful, is focus on the facts of it and get the emotions out of the equation and say, I would really like to understand this, why this, I've heard this is recommended. This is what I'm reading. Could we try this and see how it goes?
All right, great advice. This is from Emily, and Emily wants to know, why do you think it's better not to stimulate?
Genuinely curious. I can see that. And I think that's great. I, having had multiple anesthetic procedures myself and having been literally shaken awake by one of the nurses, it is the worst thing in the world. And so it's a personal choice on my end. And I've spoken with some other anesthetists and some of the folks that have VTSs in this specialty, and they just, if you're tapering your anesthetics appropriately, and if you're sitting with them, and if, you know, you're gently rubbing them and doing gentle stimulation, no problem with that. It's really, you don't want them to be shaken awake. So it's not that you can't stimulate. I just want to be, you know, don't stress them out.
Okay, another anonymous question. Did you mention lube? You lube ET?
I did.
Yeah. All right, and that they learned that in school, but their current clinic doesn't do it, and they're wondering if they should mention it to them.
I would. I'd say, you know, I learned this in school, and I'm curious as to, you know, why we don't do it here. And say it like that. Is there a reason why we don't do this here? I'd love to learn. And keep it really positive and phrasing it. Again, there's a lot of literature on it. I know cats tend to get really goopy, even if we're putting lidocaine, and I love a lidocaine in there for our cats, just a drop of it. And don't spray. I get like a tuberculin syringe and just do like 0.05 ml. So it's 0.025 on each of the laryngeal folds. It helps with the fibrillation, but it does create more mucus. So I get it, but I also, you know, that dry tube feeling is not pleasant. So again, I would get on clinician's brief and some other resources and be like, this is what I'm finding, and just have a conversation. Just, you know, what do you think? This is what I did in school. I noticed we don't do that here. Well, what do you think? And see where it goes from there.
All right, next one is from Hannah. So Hannah asks, or says, they were taught to wash circuits in warm water and chlorohex solvent when they have FIV or FELV cases. And what's your opinion on this?
That's a tough one. I'd have to do a little bit more research to see what is the most efficacious cleanser for those, especially, you know, antivirals and whatnot. I think as long as you're rinsing it out really thoroughly, it should be okay. But I'd want to make sure that I have the literature on that for you. You definitely don't want to transmit those back and forth. It may be worthwhile that you have, I mean, they are technically disposable, and there's other things that we can teach you to do with those. Like you can build your own training mannequins. So if you have an infectious case, you may just want to see what your cost is to just get rid of them and go from there. But I've been making notes of things that I have to look up, and I'm pretty sure Caitlin has too. So I will add that to the list.
Let me do that quickly.
All right. How many more we got going on here? What are we doing on time?
We're
good.
All right, we'll
keep going.
This is from Ashley. Ashley says, or asks, for a patient with heart murmur, would protocol be to use Torb and propofol?
I'm going to ask you a question back. What does butorphanol do for our patients? And if you can't answer it right away, that's okay. It doesn't do a whole lot. And it's out of there pretty quickly. Propofol, it depends. Is it the standard anesthetic rate? It really depends on what grade murmur and all the other pre-existing conditions of that patient. So I really couldn't answer that without knowing, you know, is it a grade 2? Is it systolic or holosystolic? Is there any other type of arrhythmia associated with it? What's the age of the patient? I haven't used butorphanol as part of a pre-medication protocol in a very long time. I know that alfaxalone is a pretty cardiac safe and friendly one, but I haven't had enough experience with it to recommend it fully either. So I would definitely do a little bit more digging into plums, and I'm pretty sure that the anesthesia nerds have a podcast on that in particular. So I would check that out for that more of a direct answer. Apologize, I can't answer that better for you. But I do know that Torb is kind of falling out of favor for a general induction or pre-medication protocol.
have some agreement in the chat there. I'm going to go to one from the chat before I lose it. It's from, I'm not sure if it's Desire or Desiree. What are the main things to look out for in a heart murmur dog while under anesthesia, like chest x-rays before, pre-meds, induction, and during the procedure?
That's a great question. And I think, again, it comes back to, you have to know a bit more about your patients, right? So beyond the heart murmur, what is, the structure? Have they done an echo? Have they had a full cardiologist workup? What is our concern here? What breed is it? Is it a King Charles Cavalier? Then I'm more concerned about some other valvular conditions and what we could be looking at in that term. So like AV block is a thing, and it's a scary one. But what's the age, right? So it's really what you want to be looking out for is knowing everything before you head in. So a cardiac workup on any patient that you're worried about is always ideal. Yes, chest rads can help. It can give you the vertebral heart score to know if it's got an enlarged heart. And if there's any other types of neoplasia or badness in there, to know ahead of time. But you really want to get a full diagnostic ECG with more than the 3 leads. You want those 6 leads, and you want an echo to make sure you know what the blood flow looks like. But you want to be really vigilant and keep the inhalant as low of a percentage as you can. You want to have your stethoscope at the ready. That's why I love the esophageal one. And you're really focusing on your cardiovascular parameters for sure. So again, it's going to really depend upon the patient's history and how they present and what the workup is ahead of time, and then tailor your protocol appropriately, make it cardiac safe, and make sure you have all of your interventional drugs calculated beforehand.
All right, you gotta up your Philly here. We got a lot of questions left.
Oh my God. All right.
If we run out of time, we will take these all down. I'll add them to our list of notes and we can share.
We'll get them for you
afterwards.
for sure.
Okay.
All right. Where are we at? We've got about probably time for 3 more.
All right. Yeah. Joanna, do you need to use the non-rebreather for the smaller kiddos, or can we just use a rebreather with a smaller bag?
That's a great question. And that's typically what a lot of us do and have done. It's not wrong. It's just best practice. Although if I was talking to some anesthesiologists, they would smack me out of my chair. So you've got to work with what you've got. So if you don't have a non-rebreather, then get an F circuit that has, and I can't really make it with my finger. It does, it looks like an F. So it's got your attachment and it's got a tube within the tube. And you can get pediatric versions of those as well as your pediatric wire or circle circuits, your rebreathing circuits. You don't want to, so if you have a 5-pound patient, I don't want a 1 liter bag on there, right? I want a 1/2 liter bag. Is that going to be effective on a circle system? Not really. So if you're doing exotics and neonates, you should absolutely, the best thing that you should do is have a non-rebreather. You can make it work. It's not ideal. And I would be doing all of us a disservice if I said that it's okay to do that. You can, but I would strongly advise that you look into and talk about getting a non-rebreather and make sure that you have the appropriate hookups to do so. Did we freeze? Did I freeze? Oh yeah, Caitlin, I lost you guys for a minute there. Sorry.
You're good. Caitlin, are you good to read one more question?
I can do one. I'll scroll on down there.
Okay.
Let's see. There's so many good ones. I'm not trying to high grade here. So let's see. Oh, saw one that just disappeared. Can you explain why not to spray with lidocaine? Absolutely. Can you aim it when it's aerosolized? Not really well. You can put it where you want it to go, but it's going to go everywhere. And in my experience, that tends to numb areas that don't need numbing, and it can also increase the mucus production. So if you can get a more direct approach with that syringe and just tap it on there like that. So that's why I would recommend not doing it. If that's all that you have, then you do it. But try to be very, very sparing and don't just like a generous squirt, right? Gentle. But I love the 1 ml tuberculins. Obviously take the needle off and just do 0.02 on each little laryngeal fold. It keeps it more localized, and give it a bit of time too, 15 to 30 seconds, so it actually works. And that way it's not numbing the entire oral cavity and making your job a little bit harder. These are great questions. And we'll make sure, again, like Caitlin said, we're gonna take these down, and they're hopefully recorded. Dana, maybe you and your team can help us out there, and get these all recorded in a space where we can make sure that everyone gets the answers that they need, because this is a lot and we want to make sure that you get taken care of. So thank you, everyone, for your participation and your enthusiasm and your patience with some technical snafus that we had, but we got through it. And do make sure that you keep in touch and connected with CVP, and I will let Dana close us out. But I appreciate you all. Happy Vet Tech Week, and have a great rest of your night.
Thank you so much, Alyssa and Caitlin. That was fantastic. And yes, to follow up, we will certainly export all of the questions, all of the comments. We'll share with Alyssa and Caitlin, and we'll make sure that we get you your follow-up answers for sure. With that, we also want to make sure that you get your CE credits. So this code here, if you go ahead and scan, you'll be brought to a quick little form landing page for us to go ahead and gather all of your information. I am going to also drop the link. I know sometimes QR codes can be a little wonky, so I'm going to drop the link into the chat as well. So go ahead and fill out that form. We'll leave it up here for just a few moments. Just to note, it is only for those who were able to attend the live session. So if you are engaging with the recording, we're happy that you were able to join for the knowledge and the wonderful content from Alyssa and her team. Unfortunately, CE credits are only available for those, like I said, who joined the live session. You also do need to be registered, signed up, and have your profile set up with Racetrack. So make sure that that is something that you have in completion as well in order to see your certification reflect. So anything else to add to that, Alyssa, Caitlin, or did I cover all the specs with certification?
Okay. I think you got it. Yeah. So just like Dana was saying, just bear with us as we get everything compiled between the two of our teams and get all your questions answered and all of you certificated and all of those things.
Absolutely. For those who attended and who did register but couldn't make it to the live session, we will be sending the recording. It takes us just a couple of days to kind of bundle it up, clean it up, and get it your way, but it will land in your inboxes. And keep an eye out for our next Vet Fuel. We have several sessions coming up every month, with the exception of December, because everyone is busy with holidays and all that fun stuff. So we do take that month off. But we'd love to see you back again with us for another session, and we'd love to welcome Alyssa and Caitlin back for a future session as well. Echoing what Alyssa said, happy Vet Tech Week. We appreciate you, and we hope you found this session enjoyable, educational, and we look forward to seeing you again soon. So have a fantastic night, everyone. Alyssa, Caitlin, thank you again.
Thank you, everyone. Have a great night. Take care.